all the topics are important, but we know this one is also important, and we do need to. And one thing I've realized about epilepsy relating to pregnancy, before, during, and postnatal support is that the knowledge is not out there. So it's really important we talk about it and we get the information out there. So yes, you're fine. Those of you here today, parents, carers, people with epilepsy, and also clinicians are all here today. So I know it's going to be a great learning opportunity. And Kim is here, always patient enough to answer questions. And as we said earlier, we have our the panel session coming up later today. So we've got our speakers still coming up to take questions, but I'll just introduce Kim. So for those that do not know Kim, Kim is an advanced clinical practitioner. Kim is not a medical doctor, actually. Kim is a nurse, and a proud nurse, and I'm so proud of that. That Kim is a nurse with loads of years of experience and knowledge around epilepsy, and she's a registered nurse, registered mental midwife with additional qualifications in epilepsy, complex pregnancies, child protection, pharmacology, advanced decision making, epidemiology, diagnosis, and history taking as well. She specializes in epileptic drug prescribing management and all aspects of reducing the impact of epilepsy. Since 2000, she has conducted a Women with Epilepsy service, which provides holistic care and treatment support from teenage years to support to women from teenage years to motherhood. In addition, she established and ran for 7 years a thriving community epilepsy specialist nursing service for Southampton, and after that I've done a whole lot in Hampshire and outside of Hampshire as well. Kim designed the maternity epilepsy toolkit. So for clinicians that are here that may want to know more about it, I'm sure Kim will mention it. It's called the maternity epilepsy toolkit. It's accessible. You can download it. You can, apply it to your practice. She designed it, and it's being used nationally here in the UK, and it's embedded in the SUDEP Action Professional Checklist. Remember the checklist Rohit spoke about? The toolkit is also embedded in it as well. She is an Embrace assessor and provides expert support to epilepsy charities, royal colleges, and guideline committees. She is she's an author of many professional journals. You just need to go Google the name of Kim Morley and you see a whole lot of stuff she's written about, contributed to up on there. And she has a lot of experience working in Ethiopia. She did a lot of work in Ethiopia years ago, and I've known her for a long time. When I was a student, I used to tag along in our clinics, wanting to know more. And even now, years and years later, I still enjoy liaising with Kim because there's always a lot to learn, always a lot to find out from Kim. Welcome, Kim.
We're going to be focusing today, if the presentation goes, on sudden unexpected death in epilepsy, specifically looking around before pregnancy, during and postnatally. And remember, postnatally may not be at the end of a full-term pregnancy, it might be at the end of a termination or a miscarriage. So kind of with the knowledge that what's happening here, with the knowledge that epilepsy is one of the world's oldest disease, and we know there's so much social stigma and traditional beliefs about epilepsy, and really has much changed? I don't think, because people don't like to broach the subjects of things like SUDEP. And I think that's because people are fearful about epilepsy. But we should be doing that. We know 80% of cases of epilepsy worldwide are in low to middle income countries, and many of you will be working and living in those. And we know that premature deaths in epilepsy are 2 to 3 times higher than the general population. But in low to middle income countries, that's likely to be much higher. and discussing SUDEP. And you can imagine in pregnancy, this is such a dilemma, because when women do fall pregnant, they don't then want to be hearing about, oh, and by the way, you might have a higher risk of death. So it's how we actually think about risk and risk aversion and risk mitigation. And also guidelines now are encouraging us to actually talk about SUDEP. So it should be on everyone's agenda, and it should be an ongoing conversation of risk assessment. And I want to ask you a couple of questions so people can bring it up in the panel. Does your country have epilepsy management guidelines? Because that's got to be a starting point in order to have SUDEP advice and information embedded in those guidelines. So we know SUDEP is rare, but we also know it's a fatal complication of epilepsy, obviously. And from video telemetry suites, we also know that majority of cases are due to epileptic seizures. But occasionally, in a video telemetry suite where someone has passed away, very sadly, there hasn't been a seizure witnessed or picked up on EEG electrodes. So we know there's an intricate relationship here with what's actually going on, but we also know it's more likely to occur with tonic-clonic seizures. So that's either from a generalized epilepsy or a focal epilepsy with bilateral tonic-clonic seizures. We know it's lethal, and we know there's probably a reversible cascade of evil apnea, which on the outside, can you hear me all right, Tolu?
Yeah, we can hear you. It's just glitching. It's saying your network bandwidth is low, so your
Yes,
internet seems to be playing up a bit today as well.
Let me know if you can't hear me, yeah?
So maybe you could turn off your video, then that would save you the
Turn off my video.
Your camera.
Aha.
Turn it off, then that would
let me
save
find
you.
it first.
It would save your bandwidth for your audio.
Oh, good idea. Where is my camera? Okay, right. There's me. Dun, 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 dun. Stop video. Stop. Hide self view. Stop video. Yeah.
Yeah. Okay. Let's try that.
Is that better?
Yeah.
Okay, let's try that. So we know these events. So if there's postictal central apnea on the outside, this looks like somebody's blue. So at that stage, then they're clearly not breathing effectively, but they're at risk of these bradyarrhythmias that have been seen and asystole. And we actually had a patient who was 6 months postnatal, newly diagnosed with epilepsy, who parents got to her within 30 seconds, I think it was, of the seizure starting, and realized that actually she'd stopped breathing and then there was no heartbeat, and they performed cardiac massage and they didn't get her back. So I think that in some people, in a minority of people, there's more things at play here, and some are not potentially reversible. Right. So what is the prevalence in low to middle income countries? Well, as you've probably gathered, there is paucity of evidence of SUDEP in low to middle income countries. There was a study in Japan, so some of Japan's quite affluent, and pregnancy and the postnatal year were extremely small, and the authors of that study actually concluded that it was likely because of the fact that many people with epilepsy there don't become pregnant. So a question for the panel, I want to know, do you have any idea of the prevalence of SUDEP in pregnancy in the postnatal year and the postnatal year in your country? And if you don't, I want to make suggestions that actually you could be an advocate for this, because unless you know your statistics, how on earth can you go about trying to improve things? And, you know, you can be a real ambassador for this. I really want to encourage that. Now, we do know the statistics in our country, and I've just been a chapter writer for the 2023 Embrace Neurology report, but I'm going to quote from the 2020. So every 3 years, we'll we'll pick one theme, and so it's on rotating every 3 years. So 3 years ago in 2020, we looked 22 women with epilepsy died either during pregnancy or up to 1 year postnatally or after having had their baby. Bearing in mind, I talked about miscarriage and termination of pregnancy. 18 were due to SUDEP, and very sadly, this was a doubling from the report in 13 to 15. Now, it's slightly misleading because of the fact that the previous reports only went up to 6 weeks postnatal, so the actual definition of the postnatal period. They didn't go up to 12 months. And the reason we've included that is because we know women can carry on being at risk in the postnatal year. And that's probably due to sleep deprivation, being woken from sleep, or a change in their anti-seizure medicines. Very sadly, 2 women drowned and 2 women had status epilepticus. So there were recurring risk factors that were identified, but you have to look at number 1, and this will always be either poor adherence or no adherence with anti-seizure medicines, or lack of efficacy of the anti-seizure medicines that are being taken, or the dose is ineffective, or the dose is far, far, far too high postnatally. And remember, extremely high doses of anti-seizure medicines postnatally potentially can provoke seizures. And that's why it's so important to have a plan in place if you've increased the medicines during the pregnancy, to have a plan postnatally of what you're going to do regarding reducing. So it's evident that many women had had no preconception counselling, and certainly many, in fact, most of them had not seen an epilepsy specialist during pregnancy. We do worry about medicines that we know are impacted from hormones and the effects of the increased metabolism that goes on in pregnancy and the increased blood volume. So lamotrigine can be particularly effective, but so can medicines like levetiracetam and oxcarbazepine. No safety advice was provided for many people, so it may have been that somebody was told about SUDEP, but no risk minimisation was discussed, and it certainly wasn't entered in their notes. And there was often no multidisciplinary team meetings, or no coordination or communication, and no action taken when women did report seizures. Sometimes it was just written down they'd had a seizure, but no action was taken. And no information about sleeping prone or alone. So we always advise women to, where possible, not sleep alone. We can't suddenly magic somebody up if they live alone, but we can give safety advice about living with relatives or having things like a bed alarm, etc. And we also, particularly in our last report in 2022, we're finding increasingly that people living with difficult situations with multi-comorbidities are at more increased risk. But in 2020, we particularly found it in the learning disability community, where it seemed more women were having babies with learning disability and epilepsy, but also in the Black, Asian, minority ethnic community, and those with difficulty with English, and of course those with alcohol and substance misuse, for a multitude of reasons, not just the alcohol. So if you hear about somebody with epilepsy and you're the specialist and you have heard that they're having ongoing seizures and they're newly pregnant, or they want preconception counselling, please, I beg you, make contact with them as able to prioritise them the next day or the same day. That's absolutely ideal. So let's look at SUDEP, what we found out. So for the majority of people, you must imagine what this is like for the people themselves, where nobody's actually talked about SUDEP prevention, but also for their families and for their communities. It is the most important cause of death in epilepsy. And we know SUDEP affects the epilepsy population by 1 in 1,000 adults annually. We know potentially it's up to a 10-fold increased risk of that statistic during pregnancy in the postnatal year, but certain people will have further increased risk factors. And of course, we know from the SUDEP checklist that the ages of 20 to 40 are going to be at the highest risk of SUDEP. And of course, when are you more likely to have a pregnancy at those ages? And remember, risk is not constant. So don't feel you can do one risk assessment and leave it at that. Risk changes. Our risk changes as we get, and it may be as the pregnancy has been discovered that that person's risk suddenly change because they've decided to stop taking their anti-seizure medicine. So we know from key learning from Embrace, and I'm very sad I can't reveal the 2020 because we've got that presentation. Our guidelines will come out from Embrace in October. So they want us to develop SUDEP awareness and risk minimisation for women before, during, and postnatally. We want women to be able to see a designated epilepsy care team. Well, having worked in Africa, I know for the majority of people won't have access to a neurologist. In fact, many of them won't have access to a nurse even, or a health extension worker. So I have to be realistic here with the audience, but this is our learning for the UK. And when you're actually looking at your own countries, think about the information that you want to collate and the type of service you want to embed for people with epilepsy. And being on the Tropical Health and Education Trust, training health professionals how to manage epilepsy, how to diagnose and manage it. You know, this can be with health extension workers and nurses to actually get them to recognise signs. Always regard nocturnal seizures or seizures that arise from sleep. Remember, somebody's a night worker, they're going to sleep during the day. Or if women are tired because they've been up a lot in the night with their babies, they're more likely to have a nap in the day. So when you talk about safe sleeping, talk about it not just at night. We should be developing joint standards of care. So that means communicating, doesn't it, between services. So definitely for people in Africa, I saw many of them in psychiatric clinics because there wasn't an epilepsy clinic. So, but think about where you're seeing people. And if you are with a young woman, can you communicate with the maternity services? And if they have something like HIV, communicate with them as well. So optimize anti-seizure medications before pregnancy, obviously, but during pregnancy as well, if that person's never been seen by a specialist. And rapid referral for neurology review if there's worsening of seizure symptoms. And pathways for immediate advice for junior staff. So I'll ask you to start your video. If they're out of hours, so if they're going to be accessing care from elsewhere, they need to know where to get that care. And safety precautions may significantly reduce the risk of accidents. So absolutely, you should be talking to not just the person with epilepsy, but their families, their loved ones, and potentially their employers about first aid for a seizure and how to reduce the risk of accidents and injuries. And active seizures minimise the period of time where they're unobserved. That should be considered, and that's really in extreme cases, because what you need to make sure is you don't take away somebody's independence. And for us, we do have the facility of involving social care. So that's adult social care, to do a home and work risk assessment, and to look at aids to work. So think about pre-pregnancy risk reduction. Optimally, you'll see everybody before they become pregnant. But even with a service like mine that's run for 23 years, I can't tell you how disappointing it is when people are referred to me but have never been referred during pregnancy. It doesn't happen much in the area that I'm mostly attached to, Winchester, but it certainly happens in the periphery and Basingstoke, because they go to a different area as well. We need to make sure the diagnosis is sound. That's pivotal, because if we're actually looking at a non-epileptic attack disorder, or we're looking at a long QT wave syndrome, then it's not going to be appropriate for anti-seizure medicines. But as soon as you start the pre-pregnancy care, you need to be thinking about contraception. And we've discussed this in my previous presentations, where you must make sure you check the anti-seizure medicine does not interact with the medicine they're being prescribed. You need to identify women at high risk of tonic-clonic seizures, most certainly. And you need to identify those with learning disabilities and those with a history of uncontrolled or prolonged seizures. You need to be having a discussion with families, and there's a link here to the SUDEP checklist, and I have sent Tolu this presentation, so you'll be able to actually follow this link and look at the video as well. And if somebody is suitable for surgical excision of something that's causing their seizures, that's the time you need to be thinking about it before they become pregnant. Make sure they're on the right anti-seizure medicine and regular inquiry regarding their adherence behaviours. Now, I have that inquiry at every single contact with my people with epilepsy. I never do not ask. I always ask, and I always say, how has it been for you? How have you, how has it been? You would on average be taking 14 doses a week if you're taking your medicine twice daily. How many of those have you been able to achieve over the last week? So conversations that open it up rather than just say, do you take your medicines? Because you'll often get a yes when it may be a no. Also think about the lifestyle factors, so healthy eating and exercise, but also avoiding sleep deprivation, alcohol and stress. And sometimes it's hard, but it's looking at tactics of dealing with that, making sure people have anti-seizure medicine advice during illness, particularly when there's vomiting or diarrhea involved, because that will affect their absorption. And are they taking polypharmacy or over-the-counter medicines that can interact with their medicines? And train the family members and carers about first aid and management of seizures. And this is not just pre-pregnancy, this is during pregnancy as well. Think about safety pillows. They're quite expensive. We don't know how much they're proven. You're as well to be talking to people about safe sleeping. And I've put all the links on the end where you can access that information. And having an emergency management plan. Now, I appreciate buccal midazolam has a short shelf life, and in many countries it's not available. So it might still be diazepam. Sometimes there's lorazepam or lorazepam wafers. But remember, the safety advice, as soon as the seizure stops, get somebody into the recovery position. And basic life support training of high-risk women. Also, seizure monitoring devices. We don't have evidence of how preventative they are, but we think they do help. And a recent analysis of data that Rohit was involved with, actually looking at the efficacy of the EPSMON app, and it found that women of childbearing potential with epilepsy had a low baseline awareness of risk of SUDEP. So this is the time to start talking about it. So I'm not going to go through the guidelines because we're already short of time today because of starting late, but you can catch up on this afterwards in order that this will inform your guidelines if you don't already have them. So I want to talk about Martha, and I'm going to talk about her because what we're noticing is more women with more complex needs coming through now who are more likely to have died. So this woman had had no preconception counselling. She'd booked at 20 weeks. Now, anybody who knows anything about pregnancy, this is a very late booking, and that should be a red flag in itself. She was homeless, and when she wasn't homeless, she was in a bedsit or a hostel. So she was couch surfing a lot of the time. She had focal epilepsy, but had regular tonic-clonic seizures from sleep. So you can see all the red flags here. Now, for many of you, we will have good knowledge about diabetes. So somebody with a HbA1c of such an extent, you know they're likely having a very poor diet, and also they're not taking their insulin. She also had mild learning disability. She had an increased BMI, and we're seeing more and more women when we review cases to be dying as a result of being in the severely obese range, and this applies to women with epilepsy as well. She was also smoking 20 cigarettes daily, that's what she disclosed, and had a history of substance misuse. So when we look at women like this, we're looking at a syngenistic epidemic. So that means severe and multiple disadvantage promotes disease clustering. So I've simplified it here by looking at the disease as epilepsy. And then the next thing that she had that I've already been through, her bio and the psycho problems and the social problems. Add on to that, she also had diabetes, which can take the focus off of epilepsy and substance misuse, and that's more likely to equal a negative health outcome. And that includes status epilepticus, SUDEP, or suicide. So be hyper-vigilant with cases like this, because there can be a great focus on the diabetes or the other comorbidities, but people sometimes completely forget to ask about the epilepsy. She was late booking, as I already said, that was a red flag, and the pregnancy was unplanned. So there was an absence of seizure remission, so we know straight away that's a red flag for pregnancy. There was non-adherence or poor adherence of her anti-seizure medicine. It's likely why she was going on to have regular seizures. She was sleeping alone, and she had a very poor social network. And the impact of her learning disability, you think about this, on how not only her understanding about her health conditions, but also her behaviours and what she understands about what you're telling her as well, and her vulnerability. And children and adult social service involvement, which were heavily involved with this case when they found out she was pregnant, that is going to be a red flag for morbidity and mortality postnatally. So we know women during pregnancy who have social service involvement, especially when children have had their babies taken away from them, are at particular risk of maternal death. So we're now going to talk about Jemai. Jemai is 10 weeks pregnant, and she asks you about the risks associated with anti-seizure medicines. She's had no preconception counselling. So what can you do to help people navigate risk? Just think about it. What I don't want you to just say is you could be at risk, increased risk of SUDEP, because that would be the worst thing to say to anybody. And that's exactly what happened to this young woman. They spoke about how harmful the medicines were to the baby. They said that she could experience a SUDEP, but she was worried about harming the baby, so she stopped taking her anti-seizure medicines. Now, I want you to think that no matter what the gestation, women are already thinking about the baby. They're not thinking of it as an embryo or a fetus. They're thinking of holding that baby in their arms. And if you've frightened them with saying about their medicines when they become pregnant, then they may just stop taking them, and that could be to their demise. So it's imperative to help women weigh up all the risks to inform their decision making. And if you have an inquiry like that, to discuss morbidity and mortality risk, but with risk protection, risk aversion tactics. And this should be for the pregnant woman and the mother, and potentially looking at the risk for the fetus and the baby. So the potential risks we know of major congenital malformations are different for all the anti-seizure medicines. But when you're trying to weigh up the risk, even when you look at these statistics, even when you look at the statistics with sodium valproate, still the majority of babies do not have neurodevelopmental delay. We know that risk is much higher with sodium valproate. But can you see if somebody is so frightened about taking their anti-seizure medicine, they may just decide to stop taking it. So when I look at risks with anti-seizure medicines, I'm not just thinking about teratogenicity. I'm thinking about the adverse effects of their anti-seizure medicines, the interactions, their adherence behaviours, the continuity of supply and the brand and the formulation. Is it or is it not controlling their seizures? Are they taking the wrong drug for their seizure type? Is their dose not being reviewed? Is their diagnosis correct? Are they taking polypharmacy? Because as soon as they're taking more than one anti-seizure medicine, or they're taking other medicines such as SSRIs or antipsychotics, or what other medicines they're taking, as soon as they've got more than one medicine to take, they're more likely to have adherence problems. And you see, I start thinking about teratogenesis quite long down the list. And drug increases and changes during pregnancy. So thinking about that, and also as soon as you start developing increases in medicines, women sometimes have to follow quite complex regimes, particularly when more than one medicine is prescribed. But I want you to focus on this graph now and actually look at embryology. So we know embryology is the first 8 weeks of pregnancy. And from 9 weeks, we then have a fetus. And the majority of major congenital malformations will occur in the first 8 weeks of pregnancy. Well, bearing in mind, many women are not booked for pregnancy until between 8 and 11 weeks gestation, and sometimes later. So if you start coming on board with, oh my goodness, you're taking such a high-risk medicine, you've already missed that opportunity pre-pregnancy, because you're not going to start suddenly making changes, reducing or stopping medications when they are pregnant, unless they haven't got epilepsy, unless they've got a non-epileptic attack disorder that's been proven. So looking at this, will this affect your management advice now? This graph that I referenced can carry on causing neurocognitive problems, but actually the major congenital malformation is usually in the first 8 weeks. So the pregnant woman will be thinking about the seizure recurrence. This is the risk to her, the risk of non-adherence. I say you need to be checking all the time. The risk, the hormonal effects on the anti-seizure medicines, on the levels, the risk of burns and fractures and road traffic accidents, but also please make an inquiry as to whether she's had these before, because that is a red flag for the extent of her seizures. And also think about the risk of SUDEP, drowning and status epilepticus. So also looking at the morbidities in risk pregnancy and deliver a healthy baby. But some people, epilepsy will remain unchanged, but a minority will, their seizures will increase. And you should always make sure, if you have the facility available, to actually check anti-serum levels and anti-seizure serum levels to check if somebody is adherent with their medicine. Preeclampsia is potentially higher in women with epilepsy. I find that with the older anti-seizure medicines like valproate and carbamazepine, phenobarbital, phenytoin, less with the newer anti-seizure medicines. But it's also more common in women who have got eating disorders and those who smoke. And if women with epilepsy are overweight, I've already said that can increase the risk of maternal death. So we also need to be thinking in this conversation that we're having about the risk of uncontrolled epilepsy, because it isn't just about injury, burns. It's also about one seizure bearing in mind that person may have been seizure-free, can totally change that woman's life. Her partner, for a start, may have never witnessed a seizure, or a family member. She might be excluded from her community. She might lose her job, her ability to drive, and it might affect her mental health. Also think about the impact on the fetus. And we know that even focal seizures potentially can impact on can cause fetal distress, particularly if they're focal seizures with impaired awareness. But generalized tonic-clonic seizures can lead to hypoxia, particularly when they're prolonged. Much more likely when they're over 5 minutes, because the fetus itself has got very good coping mechanisms to deal with lactic acidosis. But it is transferred to the fetus via the placenta and may lead to asphyxia, which can be the demise of the fetus. And also think about, if the mother is at risk of death, then the fetus is at risk of death, but also the fetus could be at risk of maternal accident or injury if the mother falls forward during a seizure and ends up on a sharp implement. So in pregnancy, plan to discuss how, when, and what to say to women and girls about SUDEP. Ensure individualised assessment. I cannot emphasise that enough. You need to find out when were the last 3 seizures, and also not just that, you want to see, if possible, a video of the seizures, and you definitely want a witness report. How do you know how to give safety advice if you don't know whether the woman falls backwards, forwards, sideways? Has she injured herself? How long does the seizure last? Is she cyanosed? Does she go blue during the seizure? You need to know this information in order to form your risk assessment about this woman. We know focal epilepsy syndromes, the need for polytherapy and decreased serum levels of anti-seizure medicines can lead to more seizures. We know the clearance of levetiracetam, lamotrigine, carbazepine are increased during the pregnancy. Okay, so that happens as well. Let me just move that back. We also know other triggers like non-adherence to medicine, sleep deprivation, and absorption problems of the anti-seizure medicines. So when I said I would like you to see these women as soon as possible in pregnancy, when are they start on pregnancy? And of course, status epilepticus, it is rare, but it does occur. And as you saw in our 2020 report, there were 2 cases. So bearing in mind, many people will only have access to phenobarbital. You particularly need to be aware that this medicine, if it's suddenly stopped or withdrawn, can lead to withdrawal seizures that can lead to status epilepticus or sudden unexpected death in epilepsy. So you have to be particularly aware if women are embarking on pregnancy, not to suddenly stop phenobarbital. If I was introducing another anti-seizure medicine and somebody had phenobarbital on board, I would actually probably take 1 to 2 years to change that over. So can you see the effect of suddenly stopping phenobarbital? You have to do this very slowly. You never just stop it. And I wouldn't recommend making those changes in pregnancy. You may need to increase the dose in pregnancy though. So serum analysis can be useful. It's not available in many countries. In fact, even in my area, you have to wait up to 4 weeks for the analysis to come back, which can be useful just to open a conversation for adherence, but you need to be onto clinical monitoring, knowing about these drugs and the ones that are more likely to reduce in pregnancy, and have a plan in place to start increasing in the trimesters. So I'm not going to go through the guidelines because of time. I do want to talk about SUDEP prevention. So effective seizure control and nocturnal supervision are key elements. So you're not going to suddenly magic somebody up. And if you don't have somebody to be with that person, if they don't sleep with a partner or family member, make sure you have some sort of device in place, or where they are sleeping, the doors are open and people are aware. And when they go to bed, the mattress is on the floor, no sharp implements by the bed, etc. Automatic seizure detection devices, they are likely to reduce it, but ongoing risk is essential. And there's different machine learning algorithms now, and novel wearable technology of seizure detection, but they're not available to so many people. The most pivotal thing here is educating the patients, the relatives, and healthcare professionals about SUDEP. Okay, so how to reduce risk? Now you're going to be able to click on to all these after the end of the presentation. So I've done a mnemonic here, and it's carer. Communicate, make people aware of the tools available, then do the risk assessment. So it should be individual for their anti-seizure medicine. And I've also put a link that they can actually get accurate advice about their anti-seizure medicines in pregnancy and when breastfeeding. So LactMed is for breastfeeding. Also, epilepsy safety information for everybody, the women, the families, friends, colleagues, healthcare professionals, and report in the UK to the HRA if there's been any maternal deaths or morbidity, teratogenesis of the fetus. So safety and risk assessment and awareness should be discussed at each maternity encounter. So there should be a multi-professional plan drawn up. Risk of seizures in labour is low, but recommend birthplace in an obstetric unit. Now think of an individual risk assessment, and all the facilities for doing that are on my maternity epilepsy toolkit, which will be updated and on my website as Embrace is released. The day it's released, my website will also be updated with the 2023 version. I last updated it in 21. Avoid baths and poor delivery unless vigilant supervision. And when I'm giving people advice about water, don't walk next to rivers, stream, or the sea by yourself unsupervised, and avoid being admitted to single rooms unattended, because how do you know what happens when that door's closed? And avoid pethidine, use diamorphine instead, because pethidin's converted to norpethidine, which can lower seizure threshold, and seizures can lead to risk. And if a general anaesthetic, avoid ketamine and sevoflurane. Avoid hyperventilation, because this can lead to absent seizures, and avoid triggers for seizures. And discuss adherence to own anti-seizure medicines at prescribed times. So I always get people to take their own medicines in labour and the postnatal period. Have mobile phone alarms set ready to remind them to take their medicine. And it's not their usual medicine. This could affect their seizure control. And these are just tips from my epilepsy community. I run a Facebook group, and these are tips from them as well. So it is very important to talk about risk postnatally as well, because family members will always say, but why didn't they talk about the risk postnatally? So how do we reduce postnatal mortality risks? We know the risk is low, but we should be talking about it. The triggers are stress, obviously, sleep deprivation, and once again, poor anti-seizure medicine adherence, and it may be the woman deciding. So it's talking about it's safe to breastfeed despite taking your anti-seizure medicine, and you can get all that advice and information. If you don't have your own guidelines, you can use our guidelines from the UK. And also about the pregnancy-related physiological changes that occur with anti-seizure medicines. So make sure there's a plan in place that has been drawn up antenatally to actually start reducing the anti-seizure medicine drug levels postnatally. And I usually start doing that following hemo concentration at 3 days. I'm then in very close contact with women within 1 to 2 weeks after that to start the next reduction that there's already in the plan anyway of what to do to gradually reduce down. And it needs to be individualised just in case the woman has had a seizure in labour, which is extremely rare if you're on to giving good care antenatally and make sure they don't miss their medicines. And advice regarding breastfeeding and what to do if they have seizure deterioration, and making sure they've got continuity of supply, particularly important in developing countries, and safety advice for the anti and postnatal discussion. And once again, linking up to SUDEP checklists and the EPSMON, which Rohit would have been talking about this morning. So urgent review by a specialist if there's uncertainty about the diagnosis, if there's been increased or uncontrolled seizures in the pregnancy, if there's been any accidents or prolonged seizures or status epilepticus. Remember, burns are included in accidents, and more common when women are actually cooking on open fires, which we see in many African countries. And also women taking sodium valproate because they will need their medicine review, and women who have stopped their anti-seizure medicines during pregnancy, they obviously need urgent review. Now, I've prepared a slide here for you to link on. I was going to link on it for you, but I'm desperately aware that we're very short of time. It has all the links to actually provide you with everything that you can do and provide the woman about risk assessment. Society, and I do all the pregnancy and looking after babies and young children for Epilepsy Action. There's also the Epilepsy Society link. There's the SUDEP Action link, which will take you to the details of the EPSMON app, which is also here, and also the SUDEP safety checklist. And there's the link to my pregnancy toolkit, which I say is going to be updated again as soon as the next Embrace report is released. So in conclusion, preconception is an ideal time to an opportunity to reassess the diagnosis, provide accurate contraception advice. Remember, do this postnatally as well. Support people with weight loss, smoking, alcohol, and illicit drug use. Ensure folic acid is prescribed. Regular non-judgmental inquiry about anti-seizure medicine adherence, and challenge non-adherence. If somebody isn't adherent, see what you can do to help. See who you can get in to support with that. The pharmacist, the GP, family members. What can you do to support that? Fast track referral, booking to multi-professional team if you have one. Immediate provision of safety, first aid and adherence advice, and assess risks and provide risk mitigation assessment tools, SUDEP and drowning prevention advice, and provide registration details of the epilepsy registers. Now there's one in Australia, there's one in America, there's Europe, and there's also the UK Epilepsy and Pregnancy Register, which has now transitioned to Manchester. Looking at that, also looking at management fetal surveillance regimes and identifying, isn't it? Could this woman, when she was having a seizure, could she actually end up overlaying her baby? Could she drop her baby? Think about people with myoclonic epilepsy. So you need all those safeguards in place before the woman actually delivers to make sure she has an assessment, but you've assessed her as well, if that isn't available from social care. Follow up non-attendance promptly, because it may be there's been a deterioration in the woman's condition, and make sure there's a plan in place postnatally. Provide accurate advice regarding breastfeeding, and I've provided you the link with that, and avoid admissions to single room unattended. Otherwise, the hospital could potentially become a danger zone for these women, and discuss caring for babies safely and effective, seamless, multidisciplinary team working throughout. Thank you very much. I'm going to...
Thank you. Thank you, Kim.
That's right.
And before we go into the panel session, because there's a panel session now, we'll get Dr. Eddie, Chengo, Torie joining us, and the four of us will be on here. Before we go to this, the panel session, I want to ask a question, Kim, and your best place to, respond to this. So I had a conversation recently with a young lady that's got epilepsy, and our biggest fear was, am I ever going to get married? And will anyone want to get married to me? And also, can I ever have kids? Will I ever be able to have children? And I told her, your fears are valid, but yes. And I do want you to be able to speak to that, because that's your area of specialty. Women. And
so it's a huge amount of stigma, obviously, with marriage in low to middle income countries. Not all of them, but some of them. And with that comes that family members don't disclose that the family member has epilepsy. And also some families, and I've certainly had it with Indian families in this country, where it's been not disclosed that the person has epilepsy, and it's only been found out when the young person starts having seizures. And I've even had people who've had their medicines in brown paper bags, so they don't seem to be taking a medicine either. It doesn't mean you can't get married because you have epilepsy. It's about making families aware of what epilepsy is and trying to reduce the stigma about it. It doesn't mean you can't have children. However, for women taking sodium valproate now, there is a pregnancy prevention program, and it operates in this country. For some people, for everybody who's on sodium valproate, we actually get them to sign up to a pregnancy prevention program. But it doesn't mean they can't get married. And it doesn't mean potentially they cannot go on other routes like fostering children or adopting children. Surrogacy is a little bit of a wobbly one for me, because until I can see eyeballs and research to say that if an embryo is implanted into a surrogate, that embryo would not have been affected by valproate, then I'm not confident to suggest women go down that route. But at the moment, many women choose to stay on valproate and not have children. And there are some anti-seizure medicine regimes that you wouldn't be advising women to get pregnant on. But marriage, there is no reason why they can't be married. And, knowing thousands and thousands and thousands of women with epilepsy, oh my goodness, my heart goes out to them, because the majority are such wonderful people. And I think, the more we increase understanding about epilepsy, we take away the stigma of these people in low to middle income countries can't be married. But most certainly, of course, they can have families, but it's about health professionals developing their skills in order to be able to support people. Can't hear you.
Yeah, you're right, Kim. It's about being able to support them. And I've just seen a point in there by Dr. Nkechi from Nigeria saying in Africa, Kim, there's no marriage without children. And that's one of the things. So I get the bit about, pregnancy prevention and in sodium valproate, but there are people on other seizure medication. Hence why it's important we, empower. Clinicians are trained to be able to support women doing that, because I know, Kim, you do that before they get pregnant, doing the close monitoring you have to do in your practice during the pregnancy and afterwards. So it doesn't mean that they cannot have children. It just means that there is a lot of work.
That's right. I mean, I think in the thousands of women I've seen over the last 23 years, I can probably think on one hand the number of women who have not gone ahead and had children. So, and of course, people with moderate to severe learning disability, many of those will not have children, but for people not in those categories, many women will go on and have children. And it's up to us as health professionals to make that as safe as possible.
Yes, it's making it as safe as possible. It is possible. Just
no matter how many children they have. One woman I have in the UK is pregnant now with her 7th baby. So there we go.
See, your work is cut out for you there. And a question from Dr. Khadija from Tanzania is, I was thinking about pregnant women with nocturnal epilepsy and epileptic psychosis, and what is the most safe antipsychotic low seizure threshold, and what can we do in their situation? So I guess they're on anti-seizure medication, also on antipsychotic medication. Oh yeah, and antipsychotic can lower seizure threshold. What can we do?
Right. It's always a really tricky one, especially when you've got somebody who always has a psychosis after their seizures. And we particularly find that on medicines. I've found that on medicines like zonisamide, you have to be very careful. People have a threshold, but some people can just have it as a trait of their seizure type. And you absolutely need to treat the psychosis. And in this country, we'd probably go with something like quetiapine, but we'd always have the psychiatrist involved. Now, some people will have, as you know, it's more than 50% of people, often up to 60% problem who has epilepsy, and so we often have an SSRI or an antipsychotic co-prescribed, but it will usually be our psychiatrist, especially during pregnancy, will usually go for a drug like quetiapine. And we try to avoid things like olanzapine, just because of the teratogenicity, but also thinking about these lowering seizure threshold. But I can't emphasize enough, it is so important to treat the psychosis, but dealing with somebody with nocturnal seizures, my advice would be to try and get those as well controlled as possible on the anti-seizure regime. And you might need to just adjust that when you've introduced the antipsychotic.
Thank you. And whilst we bring on, so whilst the team are setting up to bring on Dr. Chengo and Torie, so if the team can just set everyone up on the screen, Kim, we'll carry on with your questions. Kim, there's a question on YouTube, and the question is, person said, nice presentation, thank you very much. Do we have a tool to predict SUDEP among pregnant women according to their trimester?
Well, the reason there isn't that according to their trimester, it has to be an individual assessment.
Yeah.
So if you develop a tool just for the trimesters of pregnancy, so that's why my toolkit goes on, it actually talks about pregnancy advice to give at booking, and then it talks about the information about what a seizure looks like, so seizure description, and then about the anti-seizure medicine regime. And then it goes on talking about the discussion about SUDEP and all the history of seizures, etc., and the changes that have occurred in pregnancy. And then it also includes a labour checklist and a postnatal checklist, but also an SBAR, situation, background, assessment and recommendation. And the reason I haven't worded it as first trimester, second trimester, third trimester, and postnatally is the fact that everybody will be different. And if people just focus on the first part, they'll often forget the second part. And in some areas, people only get to see a specialist once. So this was really designed for women, the Maternity Epilepsy Toolkit, and their healthcare professionals. So women and their families could use it as a navigation aid during the pregnancy. So when you look at risk of pregnancy, that's why the first part of my Maternity Epilepsy Toolkit, and we can link back onto it if you want, Tolu, the first part of the toolkit does actually go into all the risk in the first part of pregnancy. And that's what the midwives do at booking. But what we do, we have a thing called Badgernet now in our hospital, and I have everything that the midwives need to discuss with the person as soon as they've booked, and they immediately fast track them to me. But the toolkit is going to be made electronic. My dear son's going to do that.
Oh, bless him.
Yes, and the website, thank God, at long last. So I have to pay for it, but never mind.
No, you're not getting a pass there because
I'm offering to pay so I can get it done actually.
Fantastic.
Yeah,
and Dr. Eddie, can you please turn on your camera, then we can spotlight you, because we can't do that when your camera is off. We can add you on to it. So really, the epilepsy maternity toolkit, it's really important. You can download it. It's accessible online. Just type it and put Kim's name on it. You'll be able to find it on Google. You can download it. You can adapt it to your practice. But I know Kim would want to hear back from you. So if you're doing that, let us know, because Kim can always, if there's anything we need to do to be able to tweak it further for your practice and write about it, please let's do that. So Kim would love to hear some feedback when you use it in practice. It's easy. It's a tool that you can, simple language. I've read it. It's simple. You can use it in your practice. And if you have questions, Kim's contact is on there. I'm sure that you can easily contact her to ask some questions. So we are now in the panel session. Yay! We've got Kim here. We've got Dr. Eddie Chengo that was with us earlier, and also now introducing you to Torie Robinson. And for those, if you don't know Torie, you should know Torie Robinson. So Torie is a person with epilepsy, but she is the founder of Epilepsy Sparks, does a whole lot of awareness and a whole lot of talk around epilepsy. We've actually invited her today to bring in the person with epilepsy's perspective to this call, because remember, Dr. Eddie Chengo is a clinician. Kim is a clinician. I am a clinician. Rohit is also a clinician. We do need to get the balance. So she's going to answer questions you may, also have around that as well. And it's really important we get it. We listen. It's really important we make sure the voice of the person with epilepsy is heard in our practice. And as families as well, we listen to families, we listen to carers. Okay, so we've got a lot of questions. Here, but I want to go to Kim, because I think I asked something similar when Dr. Eddie was talking. Kim, how would you have a conversation with a pregnant woman, someone that is already pregnant and turned up in your practice or referred to you, and you're like, ooh, because I can imagine, I kind of haven't known you for so long, I kind of know what you'll be thinking, but how would you have that conversation about risks with them and SUDEP?
Okay, so first of all, I get the history of the patient and their seizures, and I've usually got a family member or partner there as well. And then I start asking them as to what they know about the potential risk and what they already do. And it's very important to have a baseline of the person's knowledge. And if the person has no knowledge, you're starting at ground zero. And so it's about then talking about that actually pregnancy itself is its own microclimate. Things can change in pregnancy. For the majority of people, they don't change, but for a minority, they do. And if that person comes in that minority that are more likely to have seizures, like in my presentation, they've got ongoing tonic-clonic seizures, or they've got a history of uncontrolled seizures, or they've suddenly stopped or changed their anti-seizure medicine, then straight away their risk has already changed. So I modify it to the person who's in front of me. So I get the baseline first, I've got the history, I get their baseline knowledge. I also find the baseline knowledge of the person who's with them. And that's very important, especially if somebody has problems retaining conversations, which are always then in a letter as well, but you have to check that the person doesn't have dyslexia and has good understanding of the written stuff you're saying, and they can record it if they want as well, so that they have all that information to refer back to. So that's the ground thing. And then I start talking about, I actually go through, even though I designed the toolkit basically on how I go through, I then start talking about the things that we have in place to give them. So I give them a copy of the Royal College of Obstetrician and Gynaecologists Epilepsy and Pregnancy. I give them the Epilepsy Action booklet that I write for Epilepsy Action on pregnancy, and then I show them the EPSMON device, the epilepsy self-monitor. So I show them the video, and then let them look at that and say, this is very accessible on your mobile phone. If they have their phone with them, they download it immediately. So it's easy to do, because lots of things, when you're newly pregnant, there's so much information to take on board. Sometimes just doing it as you're going through it. And then I start talking about adherence and all that sort of thing to their medicines. So I have that big conversation with them. And then I start talking about their sleeping arrangements, because if you don't ask, you don't know. You can't just presume that if two people are together and they're husband and wife or partners, that they sleep together, because you can't presume that. One might sleep upstairs, one might sleep down the road, nowhere near. So you need to find out about these things, because otherwise you cannot quantify individual risk. So that's how my conversation goes through. And then I start talking about water safety, safety in the home, and depending on their knowledge as to what I provide. So I've already provided the Epsilon app, but it may be I'd like them to do their own risk assessment. So then I use the Epilepsy Society safety in the home to get them to actually relook at this safety outside the home. Do they need employers' advice? Do they need more safety at work advice? So I find out, obviously, anything that can increase their risk, such as, you know, alcohol abuse, which some women do drink alcohol in pregnancy, unfortunately, but find out other risk factors. And then I go on to start talking about mitigating those risks. So that's how my conversation goes. So get your baseline first, get your history and baseline, and then so that you'll know where you're coming, because otherwise it's ever so derogatory for a person with epilepsy, especially somebody knowledgeable like Torie, who knows so much about their epilepsy, and then you come along and say you should be doing this and that. Well, I never say should. I say this is advice. This is to reduce risk, because risk may change. What I don't start doing is I give them information about caring for babies and young children, but I don't start talking about later pregnancy risks, about looking after a baby, about labour, when I first meet them, because I usually meet them around 6 to 8 weeks. So I don't start giving them everything straight away. And the ideal idea of the maternity toolkit, it's a continuum of the pregnancy. Now, the pregnancy lasts 9 months and the toolkit lasts 9 months, and it should be referred to at every maternity visit.
Yeah. Thank you, Kim. And I love the bit where you said you actually allowed them to do their risk assessment. They need to be able to identify those risks. It's different from when someone is telling you, but when you can actually pick it out yourself, like, oh, okay, that could also help. Torie, I'm going to come to you here as well. Can you share with us, you know, when was the first time anyone ever discussed SUDEP with you, and how did you take this, and what was your reaction, and what happened as a result of this conversation?
Well, just a bit of background. So I wasn't told about SUDEP until I think I was 32, 31 or something like that. And the term wasn't actually even used. It was like, by the way, you're quite high risk of dying. And I loved the honesty there. I loved it. And I wish I'd received that earlier in life, because I was at very high risk of SUDEP. And when I list all the different things, so for instance, and I actually did this while I was listening to everybody else wonderfully speaking here, childhood onset epilepsy, poor efficacy. So I had refractory epilepsy. There was a degree of lack of compliance, sometimes largely because of the memory issues, which were caused by the drugs themselves. I had severe mental health issues, including anxiety, depression. I would binge on alcohol. I led to having generalized tonic-clonic seizures. What else? I was living alone. I was having, clusters, increasing frequency of clusters. I was getting physical injuries. And what else? Oh, yes. And I was in the high risk group of between about 25 and 40. What else? So basically, I was at really high risk. And it wasn't until I was told inadvertently by a fabulous neurologist that, oh, okay, I literally didn't know. And but I think I'm a bit of an anomaly, as many people tell you, that I really welcome being told, somebody being blunt with me and actually respecting me enough to say, by the way, you know, these are your risks and these need to be challenged if you wish to improve your quality of life. So that's kind of where I was. And I'm sorry, epilepsy brain, I've forgotten the actual question, Tilly. What was the actual question?
What did it result to? So having that conversation.
Oh, right. Yeah. So, I giggled and said, well, you know, what can you do? And he said, well, you know, obviously your epilepsy is refractory, meds aren't working for you, and would you consider surgery? And I'm very lucky I had temporal lobectomy and I was suitable for that. I still have epilepsy and I still have seizures sometimes, but things are a lot better. Now, I think caveat here though is, and something important to note, is that especially at that time, part of the reason I wasn't fearful of SUDEP was because I was so depressed I didn't really care if I lived or died. And I think that maybe we just need to be aware of that with people with epilepsy. And so, I mean, I don't come across people often who don't get scared by it, but what has really worked for me is looking at things from a scientific perspective as well, and looking at statistics which have been brought up. I think Rohit was brilliant with what he was saying before, comparing one's risk of epilepsy to maybe something else in life. So I was compare it to, this is a generalization, but to crossing the road. I minimize my risk of getting run over by looking both ways, by listening, and just think, okay, I still might get run over, but this is how I minimize my risk, by looking out. And that's how I approach my epilepsy even still today. And I'm still at risk of SUDEP, but my risk is far reduced. And that's another, I think you mentioned this, Kim, how I think it was you, I'm not sure, how people's risk can change over their lifetime. Yes. It depends. So like I get more sleep now, I'm trying to reduce my stress levels. I'm not sure that's been possible, but yeah, many things have changed. So my risk has gone down, but you still need to really keep a look at it. And also, so I'm really, really big on people with epilepsy and their family just being told. Honestly, the people I've met who are the most nervous about talking about SUDEP often are clinicians. But every single person with epilepsy or family member that I speak to wishes they'd been told earlier, whether they've lost their child or not. We have to tell people awful things in life, that's what happens. And I really strongly believe that we should be able to just tell people there are risks everywhere, but actually this is how we're going to improve your risk of not dying and improve your quality of life, by actually informing them in a way that of course is appropriate for them.
Yeah. Thank you. Dr. Chengo, when you have to work with in your environment, working with families, so let's think about working with the families and the carers now. What's their response when you have conversations about risks and SUDEP with them? What do you usually get back?
Number one, let me just give a scenario of the nature of the community or the people that we often see in the low and middle income countries, but particularly in Kenya. You know, in Kenya, even the remotest part of the country, you go and ask people, do you know epilepsy? They'll tell you, yes, I know epilepsy. And then you ask them, so what do you know about epilepsy? They'll tell you, that disease that kills, that is bad, that is a curse, that you can get it by touching somebody or something. So long story short, a very poor knowledge in terms of epilepsy. What people know about epilepsy, basically in resource poor settings and the rural region, is totally different from the West. And their knowledge basically increases the stigma and the fear and the discrimination about epilepsy. So coming back to your question, I'm very careful when I'm starting to talk about epilepsy with patients in our setting. Number one, I normally engage them understanding their knowledge about epilepsy. So after having taken a detailed history, probably with the eyewitness and everybody who probably have come with the patient, if I have a chance, I do an EEG, I sit them down and I tell them, you know what, I want to explain to you what is happening to your partner or your child or your friend, and then I'll let you ask questions, but I'll explain to them the diagnosis, what it means to have that diagnosis, the risks of convulsive seizures or the seizures themselves, ranging from injuries, ranging from bad accidents and even fatal things but you don't, I'll be honest with you, I don't put it initially that, you are at a risk of dying, because they are already struggling with understanding what epilepsy is. The community here is different. The people understanding about epilepsy is different. So you have to go slowly. You have to impact, some knowledge first about epilepsy, and so that they can understand first that this is a condition that is treatable. Because some of the questions they're going to ask is, am I going to be okay? Am I going? Of course, it's a complex answer to answer sometimes in the initial stages, but these are the questions that they ask, and you can see the fear in them. You can see the many questions that they ask about the dangers of epilepsy. So you give them solutions first. So over time now you start discussing about SUDEP, that okay, this thing can also happen, but slowly, you take it slowly. In our setting, you take it slowly. In other settings, probably, you can. I also work in a city hospital. I consult there, and there it's easier for me to start talking about SUDEP compared to the rural regions where I spend most of my time seeing patients with epilepsy. So I think it depends. It's an individual conversation thing. So I individualize that SUDEP conversation depending on how the patients, are and their knowledge base and that kind of thing. I hope I've answered the question.
Yes, you have. And really, it still goes back to the basics about myths understanding of epilepsy. We know that myths increases fear. That's all it does. There's nothing else. It is for people to be afraid. And then you wonder, but then what about cancer? What about other conditions, But then there's just something about epilepsy, and that just it's on a different level. Sorry, I'm going to come to you now, but I'm going to come to you in a bit. But I just want to go back to Dr. Chengo there as to how, and this is one of the questions someone asked earlier, knowing what we know now, right? What can we do differently to combat this, to reduce myths and stigma about epilepsy so that we can make things easier? And believe me, the UK and some of these countries did not get to this point, just like that overnight. We had issues even up until now. Their families still not being told about SUDEP. Their families still not being told about risks and managing them. So it's not like, oh, they've got it perfectly. No, they haven't. Kim and Torie will say that. But Torie, in a bit. So the question is, what can we do to change this narrative so that we can have this conversation better and improve the quality of life of people?
Yeah, so number one thing is to get policy, that is going to work. In Africa, that's what we are lacking. Okay, let me just talk about the experiences that we've had in sub-Saharan Africa, and that is what we lack. We don't have governments that support the infrastructure of epilepsy, if you like. That's where the problem starts. And once we get the government, understanding and taking it up that epilepsy should be a priority in the healthcare system, then all things are going to trickle down well. Capacity building is going to be done. There's going to be data collection that is going to be relevant and is going to inform on the areas that are relevant in terms of the needs of epilepsy in this region. Training of clinicians and specialists is a key thing. That's what we are lacking. We have very few neurologists, very few epilepsy specialists in Africa, and we are still struggling with we don't have anti-seizure medications that are affordable and effective. We have cheap and cheap medicine, but sometimes they're not as effective as you would want them to be in some seizure types. So we're still struggling with that. And I think when the government comes into play, when they make epilepsy a health priority, and then we choose to train clinicians, make sure that anti-seizure medications are available, and all this, then everything is going to be okay. We are going to discuss about SUDEP. We are going to improve the health outcomes of people with epilepsy. We are going to address all the necessary things that are pertain epilepsy in terms of improving the health outcomes of people with epilepsy. Yeah.
Thank you. Torie.
I completely agree with everything that Eddie has just said. And from all the people that I've spoken to over the years, from generally more low to middle income countries, yeah, they've just been saying very similar things. And I actually did a talk in India before lockdown and about epilepsy. And these guys were shocked that I could fly on my own, that I could talk about it confidently, and that I could even mention SUDEP, for instance. So I think it can be really helpful for us to find maybe some people who are confident about SUDEP and actually be able to communicate with other people with epilepsy and families, say we're both of the same species, and this is, maybe something that can help you accept things. But also, to put things in perspective, my dad didn't believe I had epilepsy till I was like 31, 32, because he was ashamed of it. And therefore didn't look into anything like SUDEP. So what Torie was saying, that we don't want everyone to think that, like the UK is perfect, because it is far, far from it. And like this is just part of the reason, a part of it, but people can't get, for instance, into employment because of their epilepsy, sometimes because they don't know how much about their epilepsy themselves, alongside, which includes, of course, the SUDEP risk. And actually, I was also going to say something that Eddie said, and that was, I really believe that we should be educating cultural and religious leaders about epilepsy and SUDEP more, especially given in more low to middle income countries and rural areas, and we don't have the epileptologists so much. They can be really influential for us. So just wanted to put that out there.
Thank you. Yes, you're right. And there's an organization I know of in Nigeria, and they do a whole lot of work, with churches, mosques, and things like that. Even there's a lady, Dr. Mundi, Jojam, I think her name is, in Cameroon. Our charity do a whole lot of awareness, and we do need to do that. Kim.
Yeah, that certainly happened in Ethiopia as well. Part of the THEP was actually training faith healers, etc. But what was even better and more effective than that, they've gone on to actually do lots of talks in schools, and because the children now are educating the parents, and that's been really, really helpful. So I think it is about educating everybody, and that's why it should never just be for the person themselves. I always want to talk to families or partners, because that's paramount. They often know much more about the person's epilepsy than the person with epilepsy, particularly with generalized tonic-clonic seizures.
Yeah.
You don't remember it. So
yeah. And some of us won't even know we've had a seizure at all.
That's it.
And so we can't go to our clinicians and say, oh, I've had this many seizures and this is how long it lasted. We just don't know.
Yeah.
And so, I completely agree. Families must know about it.
So we've had several questions, Kim. We've had several questions about the prevalence of SUDEP in low and middle income countries, and also the prevalence of epilepsy in itself. So the questions, I'm trying to combine a couple together here about, if we're saying we have more people with epilepsy or more prevalence of epilepsy in lower middle income countries, then why don't we have access to the treatment that we need? And because we know that not having access to the treatment increases seizures, put them more at risk, and more risk of SUDEP. Why
Well, when you don't even have accurate demographics about an epidemiology studies about the number of people with epilepsy, how on earth can you know about things like prevalence of SUDEP? So for my epidemiology module of my master's, I actually looked at the evidence in Ethiopia of prevalence of epilepsy. And there was one study there that I was able to refer to. But, you know, this was hard graft. People were having to walk, you know, miles and miles and miles through different villages and trying to get people to disclose that they actually had a family member with epilepsy was very difficult, because often they would not be brought forward or come out of their dwelling in order to say that a person in their family had epilepsy. So if you don't know the statistics of the number of people with epilepsy, then actually, you know, there's a paucity of health professionals who are actually able to diagnose and treat epilepsy. So you've got the first problem of not knowing the population. You've then got the problem of not enough health professionals being able to treat it. Then you've got a totally inadequate and often not only inadequate medications, but often poor supply of those medications. And some medications we had analysed, they weren't even what they said on the label. So we brought some home, they weren't even what they said on the label.
Yep.
So a lot of medicines can be, I found one medicine was actually half phenytoin and half phenobarbital in the same tablet. So that was an interesting one. But of course, there's lots of cheap generics, and that makes life very difficult. So I think there's potentially lots of organisations like Tropical Health Education Trust and the International League Against Epilepsy, who want to embrace low and middle income countries in developing their epilepsy services. And I'd probably say definitely go via the ILAE to see what sort of support can be put in place, because there's certainly a lot of willing healthcare professionals, but it's getting drug companies interesting. And as Eddie said, phenobarbital is cheap as chips, but it's not as cheap as chips anymore. It's gone up in price because, you know, when this is being used more, because actually there's more services for people with epilepsy, the pharmaceutical companies think, yay, we'll get more money for this. And so it's not a good way of doing it.
Yeah.
But when we compare the older medications with efficacy, do they treat epilepsy better than the newer medicines? Well, the newer medicines, there's less adverse effects. But actually the difference, there's very little difference in seizure control between them. But drugs like phenobarbital can be very tricky to manage, especially when somebody's had a long walk, maybe a couple of days to the health post or the health centre to collect their medicines, and they've run out of their supply. And then straight away, they're at great risk. Yeah. So I think it's about tackling inequalities in these countries, talking to the government services. And yeah, but I absolutely agree. There's not enough in place here to support people with epilepsy. We don't have enough epileptologists or people knowledgeable about epilepsy. We don't have enough epilepsy specialist nurses. We don't have enough people in maternity services who know about epilepsy. But it is about making this bread and butter, you know, that everybody knows about it, a bit like how do we deal with a cardiac arrest? Yes. Everybody should know how to deal with seizures.
Yeah.
And can I just add, in addition to that, also, we can help people manage their epilepsy in many cases by changing their lifestyle a little bit. I'll give you an example. I was still having tonic-clonics post-surgery, but I haven't had one for 4 years because I adjusted my lifestyle. So I still have the other ones, but my risk of SUDEP has considerably decreased. And I know this is just me, but I also know that that many people, if they can try and get a bit more sleep, I know our circumstances are different, but if they can try and de-stress a bit, if they can get someone to help them, remind them to take the pills if they have access to them. There are little things that we sometimes, quite often, I think can do. And in addition, sometimes this can even help reduce the dosage of drugs required. Like if I wasn't making these changes in lifestyle, I would be on higher doses of my anti-seizure medications for sure. So But just to put that out there, and that might be like a little intro into how to minimize risk of SUDEP. And then if you can tell people, actually, you're partially managing this yourself anyway, it might not be quite as scary.
Yeah.
Kim?
Yeah, that's basically what I do through my whole, I think of it as epilepsy. I know some people don't like epilepsy journeys with people, but when you've been the care provider for somebody for, you know, a good part of 16 years, you do become almost part of the family. And there's certainly a huge cohort of people in this country, and certainly who I came across in Africa, who choose not to go on to anti-seizure medicines. And we have a huge amount of people pre-conception who, despite advice, will choose to gradually withdraw from their anti-seizure medicine. So, of course, the paramount thing we're going to look at is reducing triggers for seizures. We've always got to do that, but we always do that in people on anti-seizure medicines as well. I think it's a very good point. It's what's covered in the toolkit about how do you reduce your own risks, and only you know about your risks. And a lot of people don't like disclosing things about alcohol, and they'll often underestimate rather than overestimate.
Yeah. And as we know, some people may just have a tiny shot of something that is a mixture of a lot in there. That tiny 10 ml of whatever could be, you know, the content of it. But let's go back to data here, because there's a whole lot throughout today. Even when Eddie was talking, Rohit was talking, Kim, Torie, we've all mentioned data, and we've mentioned about the paucity, the lack of data. It's frustrating. I can't even explain. Like, I'm doing a presentation soon about epilepsy in low resource countries, and there's no data. Like, it's literally frustrating. Now, I keep telling people, you don't need to be a PhD doctor to do research. You don't need big money to do research. We always think that when we say research, you need the labs, no, not necessarily so. We've spoken about tools today that are not necessarily available in like countries like Pakistan or Bangladesh, but actually they're available in other countries. You could take them, you could edit it, you could fit it to your practice, use it, write a paper on it, publish something about how you use it on 10, 20, 30 people for a few months. That's the start of data collection. And really, for example, we spoke about, and it's a question that also prompted this, one of the most recent questions about how do you come to the conclusion of the prevalence of SUDEP, especially in developing countries? They don't have the data. And I keep saying it, and I've said it before, that we're underestimating it. I know, we all know the numbers are not right. They may say they have a rough estimate of it in the UK. Even that is still not right. Not to talk of countries where they don't even do, postmortem. So we think about countries where they're predominantly Muslim. They don't do postmortem. They bury their dead within 24 hours. And even countries that are not predominantly Muslim, they don't have the equipment, they don't have the resources for postmortem and all of that. Hence why we still need to depend on family or people, the eyewitnesses still. But we need to gather that data. Kim, this is so important. I know we have the mortality database. We have a couple of things global, like the mortality database, I think was from SUDEP Action, is global. But really, Dr. Eddie Chengo's clinic can decide we're going to keep a database of all those that we've seen in the last few years and that way you can publish something about it. From this little community in this part of Kenya, we had 10 deaths. These are the issues that we had about it. And you don't have to have like millions of numbers, or we just need to start to get it out. And it's our own narrative. Like, it's our own, we are the ones seeing these people. We are the ones working with them. Don't let other people tell that story for us. Let us be the one to write it, put the data out. Kim, isn't it?
Yeah, you want me to talk about getting
data? Yeah.
The fact I mentioned prevalence is I felt quite miffed actually when I was researching this for low to middle income countries, as I always am, that there just isn't the information available, and maternal deaths are often underreported. And that is simply because a lot of those deaths are occurring at home. And many of those, certainly who I came across in Ethiopia, are very young girls, as young as 13, sometimes 12, who have obstructed labours. So there's more to it than just, that. And also with the government, actually, when they're revealing their deaths, that can be difficult for them. But until they start registering maternal deaths, and there should be a register for maternal deaths, and then the potential reason for that. And often it will be that they haven't actually ascertained that. Because the thing is, if you have eclampsia and you've had a home delivery, you can have an eclamptic fit and die. This is not epilepsy, but it could have been due to eclampsia. So you just don't know. And with this country, even, it's only in recent years that there's been better postmortems. They're not always done well. They're not always agreed to. And so it's not always possible to determine how the person died, especially when there's comorbidities. So I think, yes, definitely start collating your own data locally where you are. Get in touch with your governors, etc., to see whether they can start, if you're in Africa, linking up the different states, and also and countries, and potentially if you're in, I think we've got quite a few people from India, if you're in India, doing exactly the same. But I would like to see statistics arising. There was some arising when I did one article from America, but they were quite inaccurate as well. And they were it was only gathered retrospectively from the Register of Deaths. It hadn't been reported by the individual hospitals, because you have to remember, hospitals actually see this as a failing and actually don't want it out in the public arena. And so, that makes it even more difficult. And then the paucity of numbers with Japan, it wasn't even worth putting on there. I think there'd been 2 deaths. But they said it's probably because the majority of women with epilepsy are not becoming pregnant. And I know that's not an issue in Africa. So we potentially got a lot of pregnant women with epilepsy if their families have allowed them to marry, or if they've been married. But there is no data. So that's what we want to accumulate. And if I can assist with that at all, just let me know. I've had a lot of experience, obviously, with Embrace, but yeah.
No data. I think it's unacceptable, and we do need to start putting together this little bits of research. We will be launching one in September at the ILA Dublin, because I'm very passionate about it. I don't have all the money of the world, of the UCBs and all that, but we can start something to start to create the awareness, to get the the organizations to get involved in it as well. Especially you start to think, who are those actually regulating drug companies? Why don't we? Who are those? Who are those that are in this place of power? Kim and I were nurses, Torie. We don't have that power, but we do need to get that data out there so that some people, whoever they are, can actually listen. How on earth did we get COVID-19 vaccines out there quick enough? And yet we've been talking about anti-seizure medication for years, and we're still on phenobarbital, and some people don't even have access to it. Torie, quickly before I go to I'm not even going to go, because that could take me into a rant for hours. So,
okay. I think another thing worth communicating to the general public, as well as, of course, leaders and influencers, decision makers, and that includes governments actually, is the fact is that SUDEP doesn't just affect one person, the person who dies. It affects the entire family, but then in addition, it affects their friends as well. If they're in work, it affects them. A bit like how epilepsy actually affects all of us as a species, SUDEP does too. It's just that people don't know what it is that that has caused them that pain. The person's died, but they don't know a lot of the time that it was SUDEP. And if they find out that all this pain was caused because it was possibly something preventable, it's pretty horrific. But anyway, sorry, my initial point was going to be that we can literally save our governments money if they help us reduce SUDEP risk, because we're going to have generally a healthier, happier population.
Yep.
And so I think that's just an important message. If anybody here has access, even if it's just a little, you know, a twiddle off to somebody in power within your country, this is costing lack of care and education for people who are at risk of SUDEP or who have experienced SUDEP is costing them money.
Thank you, Dr. Chengo. A question, it's a combination of questions. I'll put them together. I suspect from a family member or an advocate. So what is the best food for people with epilepsy? What kind of, I'll probably say what kind of food rather than what is best food, because what you eat there is different from what we eat here. So what kind of food? And what are the best medication? What is the first aid to give someone under crisis, when they're in crisis? And are there medications to be avoided when experiencing seizures, when having seizures? It's a lot together, but I think it's just, yeah.
You're muted.
You're still on mute. Yeah, that's better.
Okay. All right. Thank you. So that's a lot of questions. But anyway, so you started talking about food. What's the best food? That's interesting. But I normally tell people what doesn't harm you. For example, culturally, you take, then take it. I don't think whether there are studies that have shown that certain foods basically can cause seizures. But of course, we know there's some protein, probably. I have experienced also there are some patients that, for example, I had this patient who seizures was triggered by milk. That was strange, but immediately they stopped using milk, their seizures went down, and the next time he had a seizure, it was when he took ice cream, and ice cream has milk. So, so I think it depends on a person, but I think foods are not contraindicated, and don't take that that is not good for you. So we also need to keep healthy. So avoid things that will not keep you healthy in terms of a balanced diet and that kind of thing. I think answering about first aid, what did they ask about the drug to use in first aid?
What first aid to give when they're having seizure?
Yeah, so in our setting, I think what we do is the protocol that we are using is a benzodiazepine first. So we do a benzodiazepine. It can be diazepam. That's the commonest that we use. And midazolam will be the last one, and we give it in infusion. So we start with diazepam. We go to the ones that are available basically in our facilities. We'll go to phenytoin or phenobarbital infusion, and then that's it. If they're still having seizures, we could do sodium valproate, but a lot of data has that sodium valproate is not as effective, but it's in the protocol, so we use it. And then if seizures still continue, then we go to midazolam infusion. That's how we handle status epilepticus in our setting.
Yeah. And so, any medications to be avoided when they're having seizures at home?
When they're having seizures at home, medications, penicillins will basically not be the best to use when you're having. Some of the penicillins basically lower some anti-seizure medication if you have an infection. So I'd rather do other antibiotics rather than giving penicillins in acute phases. Yeah.
So, and knowing that in some countries there's the abuse of antibiotics, just load your body up, even if it's a tiny sneeze, you give antibiotics for it. You're abusing it, and it's not appropriate.
Yeah, it's not appropriate. But maybe just to add on, I think what we were saying in terms of education, in terms of making people understand epilepsy more, I think the school programs are becoming very good in our setting. we try as much as possible, to start from there. And we share so much. And, it also gives us a platform to answer questions that the students themselves would want to know. So every time we go, of course, we tell them what epilepsy is, what are the causes, the first aid of epilepsy. But then you look at the questions. When you come back and look at the questions and you analyze, you see that there's so much that they need to know and understand about epilepsy. So again, I totally agree with you, Tolu. I think we need to do our own research. We need to have our own data, so that we can represent our communities. We can also have, evidence that is going to help in improving the health outcomes of people with epilepsy, be it seizure control, be it addressing SUDEP and the stigma in epilepsy and everything about epilepsy. Yeah.
Thank you. And we are happy to support Kim. We have colleagues that are happy to support individuals, clinics, organizations that really want to do research. We're happy to support you in our own way. And someone has put in the chat box that the best medication is the best medication for the patient. So it's not about, sodium valproate is it and everyone is on sodium valproate. No, it's what is best for that person. That's why it needs to be tailored to the need of that person with unique combinations. So Kim, there's a question here for you. It says, can eclampsia or preeclampsia be regarded as a problem or a condition that may lead to SUDEP? So there are two parts to it. I'll let you take that one first. You're mute. Okay.
Sorry, you had to do it.
Sorry.
Yeah. That's okay. So preeclampsia is a condition where you can have high blood pressure, proteinuria, and edema. It's not necessarily you will go on and have seizures. Eclampsia is seizures. Now, very few women actually will end up having preeclampsia or eclampsia with epilepsy. It doesn't specifically increase your risk factors. I do get worried with medicines like carbamazepine slightly increasing those risk factors. What you have to think about is the people who have eclampsia have a seizure. And so do they go on to develop epilepsy? Well, there isn't a huge amount of research about it, but the research out there, and I've certainly come across 2 patients who have had eclamptic seizures in the past and have gone on to develop epilepsy. Now, is that because of the eclamptic seizure, or is that because they had profound hypertension for quite a prolonged period of time, which has caused small vessel disease in the brain? So it can be multifactorial, but certainly there should be, for somebody who has an eclamptic seizure, then they should have some sort of, they should notify the DVLA if it's the UK or whatever the organisation is in your country. But not particularly. I don't ever so worry about the majority of people unless they're overweight developing preeclampsia who've got epilepsy. And I say that particular group of valproate, which I so rarely, I can't remember the last one, of pregnancy. So somebody coming through on valproate, because that's more likely to lead to weight gain again. But I say there is a potential link with eclampsia and epilepsy, so going on to develop epilepsy.
Thank you. And the second part of the question is, sleep deprivation is one of the internationally recognized steps in preparation for routine EEG procedure. So should sleep deprivation be stopped in the preparation for EEG procedures, since we know it can increase?
I wish it was stopped. I don't know why anybody does it. I always recommend 24-hour or 48-hour EEGs rather than sleep deprived. I think it's the most terrible thing, because invariably the person doesn't have a seizure during the sleep deprivation. They go home and have the seizure after the EEG. And that doesn't tell the clinicians anything about where the seizure originated from or help with the diagnostic procedure. And I think potentially EEG is quite a crude method of actual assessment anyway. And yes, I think it's quite barbaric. I don't know if I'm the only specialist who feels that way, but certainly one part of my trust where I work, they very rarely do sleep deprived, and the other part do. But I think it puts people at extreme risk of seizure. You're absolutely right.
Yeah.
But if they're trying to get diagnostics, then I think there's potentially better ways of doing it. And haven't we revolutionized epilepsy diagnosis now with things like WhatsApp, where we see video recordings of seizures? And this has helped so much, is less crude than EEGs. Of course, EEGs will tell us where the seizures are originating from, it'll tell us whether it's 3 Hz spike and wave, etc., etc. But it is a crude investigation. And where possible, I try to avoid recommending sleep deprived. And there are better ways of doing it, video telemetry if it's available, or 24-hour, 48-hour EEG. So go home with the leads on.
Yeah, and I know that some people, when they, let's say they've had to do sleep deprived EEGs, they keep the people in the clinic longer, because there's the risk that it's when they're actually on their way home or when they get home that they end up having the seizure.
Or the next day. And often people with epilepsy who've had stress, they don't have the seizure during the stress, they have it on the downtime of the stress. So I expect you found that, Torie.
Well, actually, well, actually, I was thinking you can have the seizure later. That's often what happens with alcohol as well, isn't it? You don't have it on the night, you can have it the following day.
That's it. Yeah.
But actually, what's interesting in your point, this happens a lot. People will have, say, video telemetry. They can be in for a number of days. They don't have a seizure, and like say they go home and have one. And one reason, at least in my case, was I was just so chilled out in hospital because I had a stressful life. And then I go back and have a seizure. So they had to reduce my drugs even more. But for me, that worked because there wasn't any other way to, you know, identify where my seizures were originating from. So it can work, but it can be, people hate it, understandably.
So Torie, there's a question here for you. I'm sure you'll cover this. So this person said, hi, Torie, I'm sure you'll cover this. But as we learn more about SUDEP, have there been any major changes you've made or have considered making in managing a busy day-to-day life and schedule? What do you do?
So it's not just about SUDEP for me, it's about overall quality of life. And the risk of SUDEP kind of comes into that, I guess. I will get as much sleep as I think I need, or I'll try to. That's a huge one. It's about avoiding seizures as well. So if I try and avoid seizures, the methods I use to do that reduce my risk of SUDEP as well. So I'll try and take my medications all the time. I'll try and get enough sleep. I try and avoid tonic-clonic or secondary generalized tonic-clonic seizures by doing the aforementioned. And what else do I do? Basically, all the stuff I do to try and minimize seizure risk, I do to minimize SUDEP risk. And that's all I can do, really. I do live with somebody now, but he sleeps like a flipping log. He would never know if I had a seizure in my sleep, I kid you not. So that's what I do. I just minimize my risk and I get on with my life. Because the actions I take to improve quality of life, taking into account that epilepsy is part of that, decrease my SUDEP risk. And I really like the way of looking at it like that, because it doesn't seem like, oh my God, I'm scared of SUDEP and I've got to do everything to try and stop SUDEP. It's that I'm trying to improve my overall quality of life and my overall health, and that simultaneously reduces my SUDEP risk.
Thank you. And we're about to wrap up now, but I'll take one question that someone has just asked, and it's about levetiracetam. Kim, before you go, because I know you need to go, what's your advice to physicians on the prescription of levetiracetam, knowing that the World Health Organization has recently added it to the essential medicines list for both adults and children?
I think levetiracetam, once again, it's an individual assessment when a patient goes onto it. We know it's one of our safer anti-seizure medicines to prescribe in pregnancy. It doesn't suit everybody. So some people with generalized epilepsies will go on to levetiracetam and have multiple seizures. And actually then the physician often will keep titrating the medicine up, and actually they get more and more seizures. You know very early on if this medicine's going to work. And when it works very effectively, often at low doses, 500 twice daily, sometimes lower. It can be very effective for status epilepticus. And so it's when you match it against phenytoin, it has a very good safety profile. But you have to remember, with high doses of levetiracetam, which are used in status epilepticus, you can actually induce a psychosis. And also, not everybody tolerates levetiracetam, so it may be absolutely brilliant for their seizures, but actually nobody can live with them because they've become absolutely unbearable. So it can be a good drug for some people. I think it's certainly worth trying, especially for your generalized epilepsies, on those you would not prescribe sodium valproate for now. But I would always, my go-to, first of all, would always be lamotrigine. I think it's often not the go-to because it can take quite a long time to titrate, whereas we start it at 25 milligrams once a day if it's prescribed on its own, and titrate every 2 weeks. And only when you get to 50 milligrams twice daily, you're at the lowest therapeutic dose. But if you want to cover somebody, if they've had, you know, some nasty tonic-clonic seizures, then you can always add clobazam or a benzodiazepine until you get the drug to a therapeutic level if you are choosing lamotrigine. So my go-to, first of all, would be lamotrigine. But then if they were allergic to that or it wasn't efficacious for their seizures despite titrating it further, then I would go to levetiracetam for somebody of childbearing potential. I think for some people, it's a very good medicine. For others, it's absolutely the worst ever for them. So I think, once again, this has to be an individual assessment. But I can't say it's better than drugs like phenobarbital. All I can say, it's likely to have less side effects than phenobarbital, but whether it will control the person's tonic-clonic seizures as well is another question.
Thank you. And like Dr. already said earlier, it's not available in a lot of countries,
It's
and
not
even if it is,
available in
it's too expensive and all that.
That's
So
right.
let's see how this goes. But thank you, and this is where we'll let our panel members go because I know Kim needs to leave. Torie, thank you so much for the time. Thank you. And if there are other questions on there that we've missed, we'll pick it up. We'll send the email to our speakers, and they can just write to it, and we'll send it to everyone as well. But thank you, Hadi. Thank you for the time. Thank you for bearing with us, and we'll let them go. But I've got, before everyone wraps up and go, I've got final announcement before we go, but I'll let our speakers leave now so I can share my screen, and then we'll wrap up for today. Yes, Kim?
Before we go, somebody's just put, should we treat functional seizures as the epileptic seizures? No.
I said no because they aren't epileptic.
They're not epileptic. Please don't treat them as epilepsy. No, treat them as functional seizures. So a functional neurological disorder with appropriate counselling, but not with anti-seizure medicines.
Yes.
Thank you. Before I went. Bye-bye.
Bye, everyone. Thank you. Thanks for the invitation, Lou. Bye.
For those that are still our participants, I just need to share one or two slides with us. Thank you, Dr. Chengo. I'll be in touch. Let me just share my PowerPoint quickly and we'll wrap up. So we've just finished our panel session, like we know, and parting words, it's a big thank you to our speakers, a big thank you to everyone that registered, that attended, those that attended on YouTube and on Zoom, and thank you for bearing with us with the technical issues, but we appreciate you. And yes, and also thank you to our sponsors, Danny Deed Foundation and Rowe Foundation, for making this happen. If you've got any questions about this, you're a person with epilepsy or a carer, advocate, clinician, you have more questions, feel free to send us an email using the email address that I've been sending you emails in the past few weeks. And then what next? So we have our feedback form, which we will send. Let me see if I can put that in there for you quickly. Let me see if I can get that. So we have a feedback form that is available. We'll send it to everyone by email. Please complete it. We need your feedback. We need, comments about the content of the presentation so that we can improve this training.